One I had conducted this sometime before, and it'll be a very short session, about 10 cases only. So I'll share my screen. Yeah, I would welcome you to this Pediatric Orthopaedics session. This will be an interactive session. So I'll be asking questions to anyone, and anyone can interrupt me, I don't mind. But please identify yourself and tell me which your institution from. And I would welcome suggestions for improvement, very constructive criticisms. You can either tell me directly, you can phone me, or you can WhatsApp me, or you can email me. That's my email address, and that's my WhatsApp address. The same number, you can phone me also on that address, number. Okay. Balu, shall we start? This is
Yes,
starting,
sir.
right?
Yes, sir. Yes,
Yes, sir. Yes, sir.
Yeah. Now, can everybody see the screen?
Yes, sir.
Fine. One minute, let me just, yeah, fine. Now, this is a 2-year-old girl with a deformity left knee. Now, what is the condition? What are the clinical features? What are the radiological features? How will you treat her treat this particular patient? Okay, let's have the answers. Who's answering, please? Karthik?
Yes, sir. It's infantile Blount, sir, of left knee, sir.
Yeah.
The clinical since it's less than 3 years, it is infantile Blount. So there'll be varus, which is at the knee, which is centered at the knee,
Yeah.
and we can make use of the Ceriyan curve, which is physiological progression of varus and valgus. So till 18 months, the child should reach neutral angle, and from 18 months till 4 years, they'll have valgus, and at 7 years they reach the normal valgus of adolescence.
Okay, that's fine. But what about this? What are the clinical features of this particular case? You said infantile Blount. Yes.
Yes, sir.
What are the clinical features?
Features in the sense the patient presents with the patient parent presents with deformity, sir, of the knee.
Yeah.
That we should ask a history of any previous infection or trauma.
Excellent.
Then any other features of rickets, sir. We should examine for any other features of rickets or any other metabolic cause of virus of the knee.
Excuse me 1 minute, please.
Yes, sir.
Hari. ശരി ശരി, ഞാൻ ഹരിയെ ഇച്ചിരി കഴിഞ്ഞിച്ച് വിളിക്കാം. ഞാനിപ്പോൾ ഒരു മീറ്റിംഗ് നടന്നുകൊണ്ടിരിക്കുക. ഞാൻ ഇച്ചിരി കഴിഞ്ഞിച്ച് വിളിക്കാമേ. Yeah, sorry for the interruption, Karthik.
So we should check for features of rickets, sir. Any other features of metabolic cause of genital varus?
Yeah. Now, what do you expect to see in rickets?
Rickets, we should examine from the head to sir. Head, any frontal bossing, closure of physis, sir. Then to the wrist, we'll have to examine for any widened physis, and in the chest we'll have to look out for any accent groove or rachitic rosary.
Okay.
And
that's about
yes, sir. examination part, there is one test which is a cover-up test,
Yeah. So what?
where we cover the
Yes.
middle cap of the leg and look for the femur and tibial angle. If it is a normal physiological varum, there should be a valgus of the between the femur and the tibia, between the thigh and the proximal third leg. But if it is due to a pathological cause, then there will be persistent varus between the thigh and the proximal third leg.
Okay. Now,
X-ray wise.
now we'll see the X-rays later. Now, just tell me what you see in this gait. She's walking a little too fast. But what do you see in that gait? What is the striking feature in that gait?
Varus thrust gait, sir.
Lateral thrust. It's not lateral thrust.
Lateral thrust.
Okay. That, I mean, it can occur with any severe varus deformity, but lateral thrust with these features suggests a Blount's disease. Now, what are the radiological features of Blount's?
Radiological, we have to calculate the Drennan's angle, sir.
No, I mean, see, okay, fine, but suddenly, I mean, you get these X-rays. Suddenly, they give you an X-ray. What all of identify the radiological features. You may not have time for calculating all the angles.
There will be metaphyseal beaking, sir, at the medial, sir.
Okay, that is one of the features. Anything else?
We'll have to look out for any facial, epiphyseal or metaphyseal dysplasia, sir.
Or irregularity, you mean?
Yes, sir.
Then what else? Okay, anybody else? Shinas? Shinas, please unmute yourself.
Sir, from the X-ray, we have to calculate epiphyseal, diaphyseal angle and epiphyseal.
Yeah, that is fine, sir. In a very busy OPD, will you be able to do that? The features that are very striking on the X-rays.
The mechanical axis, sir.
That is.
Mechanical axis will show a varus. I mean, it will pass medial to the leg. So,
joint,
okay.
joint angle.
Yes. Now, forget about these angles. What are the just features? I mean, without measuring anything, what can you? I mean, how can you say from the X-rays that this could be a Blount's disease?
Sorry, sir.
How can you say from the X-ray in the outpatient?
The pathology will be the proximal tibia, sir.
That's fine. Even in genu varum also, it can be in the proximal tibia. Even a fascial arrest, it can be in the proximal tibia anywhere. So that is, I mean, okay. Anybody else volunteering?
Metaphyseal beaking.
Metaphyseal beaking is one, Hari. Then what else? Metaphyseal beaking can occur in severe genu varum also. So that is not a, that itself is not a feature. Okay, I'll show you. Okay, now these X-rays. Now tell me, what all do you see on the X-rays? Yes, Hari, what do you see on the X-rays?
Medial downsloping of the joint line and
yes, medial downsloping of the epiphysis. Then
step. So it's a medial
widened and irregular physeal plate.
Yes, excellent. That is what one of the answers I wanted. Irregular physeal plate medially. Yes. Then what else? Yes, Pavan. Yes. Anything else, Pavan? Nando, yes. What else? Can you be a little more clearer? Who's talking? Pavan is talking? Your net connection is not that good. Okay, Abin. What else? They have mentioned about three features. One is a sloping epiphysis, irregular growth plate on the medial side, metaphyseal beaking. Now, what else do you see? Two more features. Okay. What about the epiphyseal-metaphyseal junction? Is it not an abrupt angulation, or the metaphysio-diaphyseal area?
Yes, sir.
Is it not an abrupt angulation?
Yes, sir.
That is one more feature. Then what else? What is the position of the tibia in relation to the femur?
Lateral subluxation.
Yes, lateral subluxation. Yes, exactly.
Okay.
So the features, now you can see all the features now. Varus angulation at the epiphyseal-metaphyseal junction, abrupt angulation. Then medially sloped epiphysis, widened irregular epiphyseal line medially, and lateral subluxation. So these are the features and prominent beaking. Okay. Okay. This diagnosis is reasonably easy. What all do you see in the picture? Four-year-old shortening deformity leg. Tell me what all do you see? Yes, Sadish.
Sir, this is a 4-year-old child having a pseudoarthritis of a tibia, showing a MAC outlet spot.
Ovulate spots. So what does that suggest?
This is a neurocutaneous marker for the association of neurocutaneous deformity.
Yeah. Now, what all deformities? I mean, so it's a congenital pseudoarthrosis of the tibia. That's fine.
Other congenital deformities such as arthropericosis congenita.
Okay.
PV.
You got the diagnosis. What is the commonly used classification?
Crawford classification.
Which one?
So Crawford or Boyd's? There are two
Yeah,
classifications. Boyd's
basically
classification
Boyd's
and Crawford.
classification and Crawford classification. Crawford is by
Yes.
Alan Crawford, who's done a lot of work on neurofibromatosis. Now,
Yes.
how do you treat this child? I'll come back to the previous one. How will you treat this child? Yes, Sadish.
With a fastening of bone ends with a bone graft and close reduction and internal fixation with intramedullary nail.
Intramedullary nail. What intramedullary nail? You're right. Your answer is right. Now, two things I want to ask you. What intramedullary nail would you use?
Telescope.
A telescoping nail rod is one thing. Yes. What else do you? What else? What is the other option?
Commonly, sir, tense nailing. Preferably tense nailing in.
Tense nailing. Okay. Yeah. Okay. Then what else?
Ilisaro.
Or Ilisaro fixator, ring fixator.
Okay. Now you said something about bone grafting, isn't it?
Yes.
Now, what bone graft would you use? No, that is. What are the accepted methods of treatment? Tell me that. You have already
Boyd's
told
dual
two.
onlay grafting and fibrillar vascularized grafting.
So the sure methods of treatment are intramedullary rodding and cortical grafting from the opposite tibia. Okay. Freshening up to vascular bone, cortical onlay grafting, from the opposite tibia. Why cortical? That's the second question. Now, when you operate on this case, what is the first thing you do? What is the basic pathology here in the congenital?
We'll have to remove the synovium.
Synovium or something else?
Hamartoma.
Hamartomatous.
Hamartomatous
This
periosteum.
hamartomatous tissue at the hamartomatous tissue has to be removed, sir.
Because that is what is causing the graft absorption. So why did I say cortical graft?
The cancellous graft will get resolved.
Cortical grafts are registered
Exactly.
for absorption.
Function.
Yeah, cortical grafts gets absorbed less easily, and one of them is one of the methods of. There are 3 accepted methods of treatment: IM rodding and cortical grafting. The second method is Ilizolo ring fixation, and the third method is vascularized fibula graft. Now, I think the most successful, the best results are obtained by IM rodding and cortical grafting. Okay. Now, this is the Crawford various classification: non-dysplastic, dysplastic, type 2A, all these things. So that's not very correct. Now, can anybody read this? Can everybody see the screen?
Yes, sir.
Yes, Nandu.
It is.
Yes.
What is the diagnosis?
Congenital.
Yes, it's congenital.
Medial bowing.
Congenital.
Postomedial bowing, sir.
Okay. What is the
Congenital
Medial
prognosis?
bowing.
Correct. What is the prognosis?
Prognosis is good, sir, with conservative management.
Yeah. Now, would anybody praise her? Would you praise her, Nandu?
Only symptomatic patients, sir.
What symptomatic are you talking about? What respects
Pain or a pathology. Pain on it's 1-year-old girl. No need to brace.
1-year-old girl,
No
if she
role
has
for
pain,
bracing.
she wouldn't be walking.
For a 1-year-old girl, sir, there is no role for bracing.
Is there a role for bracing in this condition? Tell me that.
No, sir.
Yeah. Okay. And how do you treat her? Now, somebody said prognosis is good. Yes, good with. How do you treat her?
So we'll have to follow up conservative management.
Yeah. Now, conservative management is good. Now, tell me what gets corrected, what doesn't get corrected. Yes, Pavan. What gets corrected, what doesn't get corrected?
Shortening doesn't get corrected.
Yeah, the deformity by and large will get corrected to a large extent, but the shortening doesn't get corrected. Now, various methods of treatment are there. What are the methods of treatment? Yes, let's have some answers, please.
So, if shortening is up to 1 to 2 centimeter, we can go for heel rise from inside or
Yes,
outside.
exactly.
If it is more than up to 4 to 6 centimeter, we can go for limb lengthening or opposite side shortening or guided growth.
So why did you say guided growth? What is the role of guided growth? What is the role of guided growth here? You mean contralateral epiphyseal disease? Do you think that is needed because the shortening generally never exceeds 5 centimeters?
Yes.
So you can conveniently lengthen it. Okay. Now we'll go on to the next one. Now, what is the diagnosis? What is the diagnosis?
Anterolateral bowing.
Yes. What is the prognosis?
Anterolateral bowing most commonly in pseudo.
Yes.
So it will be bad prognosis.
Yeah, it's anterolateral bowing. Okay. Then what else would you look for? What is the prognosis in this case?
It will progress, sir.
It will progress to what?
Pseudoarthrosis.
It is
Pseudo-
a deformity most likely to fracture.
Yes, exactly. Most likely to fracture, which can go into pseudoarthrosis. So how would you treat her now? Or let's say
Bracing.
where she's around, yeah,
Bracing.
bracing. As early as possible. For
Protective
the time being,
intramedullary
when
bending.
she's 8 years old, 8 days old, some protective splitting. Once you're able to measure a brace, it's always better to measure the brace. Now, what else would you look for?
So do we start the bracing once the child weight bears or start right away when we see the deformity, sir?
I would say when the child is old enough, big enough to be measured for a brace, I would feel safer to brace her.
Okay.
Because once you get a fracture, it becomes very difficult for everybody.
Okay, sir.
So once she is big enough for a brace her as early as possible. Okay. Now, what else would you look for?
Neurocutaneous markers.
We have to look
Yes.
for neurocutaneous markers.
What else?
Association with neurocutaneous.
What else? Neurocutaneous markers, yes. What else? Something in the spine over a period of
Scoliosis.
time.
Scoliosis.
Yes, scoliosis. Some of these scoliosis, they progress so fast. So always watch out for scoliosis. I mean, in an 8-day-old baby, you may not see that, but observe for scoliosis.
Look for other areas of similar lesions because its association with fibrous dysplasia is common.
Yes, exactly.
Meningomyelocele.
Meningomyelocele generally does not occur with this. Okay. Now, male baby, 1-day-old, swelling, deformity, elbow. Now, all these points are important. Male baby, 1-day-old, swelling, deformity of the elbow. Diagnosis, cause, treatment, natural course. What is the yes? Who's going to answer? Now, let's see somebody who has not answered. Yes, Amrutraj. Why don't you unmute yourself and answer the question? Amrutraj. Amrutraj, unmute yourself, video on. Srinivas, please unmute everybody.
എല്ലാവരും അൺമ്യൂട്ടഡ് ആണ് അവരവര് ചെയ്താലേ സാർ അൺമ്യൂട്ട് ആവുള്ളൂ.
Okay, then let's have Ando. Ando, please put your video on also. Let's see you. Yes, Ando. What is the diagnosis? You've seen both the X-rays. Come on, even if you're wrong, this is a forum for making mistakes. It's better that you make your mistakes here rather than the exam hall.
This is a case of elbow dislocation with olecranon fracture, maybe coracoid fracture.
Yeah. Now, two things. Does elbow dislocation occur in a 1-day-old baby?
Birth injuries, maybe possibly.
Birth injury, yeah, it is a birth injury.
Supracondylar.
It's usually, but what is the injury that has occurred?
Supracondylar fracture.
You are almost right, but there is a better word for that. It is a supracondylar fracture. Yeah, Not exactly, but
Salter
you're,
Harris.
yes, Salter Harris, come to the point. Yes, you're nearing there.
Facial separation.
Yes, exactly. Type 1 epiphyseal separation, distal humerus. Now, which direction does it occur usually?
Posterolateral is the most.
Lateral.
Most of the time it is posteromedial for some reason, not posterolateral. And how do you treat it?
You have to reduce it.
Yeah, within the first 3 days, if you can reduce it and put a POP slab. Some people advocate pinning and all, but I think that's too much. And what is the natural course? Suppose you leave it untreated. Now, I said first 3 days you treat it. After the first 3 days, if the child presents after 1 week, would you treat it?
Leave it alone and osteotomy later.
Yeah.
No, we have to
No.
reduce.
Yeah, leave it alone and then?
Osteotomy later at a later stage. Osteotomy and correction at a later stage.
Yeah. Now, what is the natural course of this? Most of the times.
Remodels.
Yeah, it remodels. Why does it remodel? Most of the time it remodels. It may take a long time, but why does it remodel? Yes, Ando. Okay, Bivin, why does it remodel? What is the reason for it being remodeling?
It's a growing end of the bone, so remodeling is much easier at the growing ends.
Now, does a varus deformity in a supracondylar fracture, it is also growing under the bone? Does it remodel?
Displacement in the direction of motion.
Displacement in the direction of motion. See, first of all, you have to understand that basically these are epiphyseal separations. These are translational deformities, not angular deformities. See, angular deformity not in the plane of motion like a varus deformity does not remodel. Now, this is a translation deformity, posteromedially, posterolaterally, anteriorly, posteriorly. They all remodel. The reason is the reason why remodels is it's a translational deformity. Did you understand that?
Yes, sir.
That's the reason. So most of them remodel. You can try a close reduction within the first 3 days, but after that, please don't do that because you will create a permanent damage. Okay, we will move on to the next one. Now, 7-year-old boy, painless clicking of the elbow. What is the diagnosis? What clinical finding you would expect? What is the line of management? Now, starting with, let's say, Gautam, yes.
It's a congenital radioulnar synostosis.
Yes, what clinical finding would you expect?
Supination and pronation is restricted here.
Be almost nil. Now, what will be your line of management?
Osteotomy and fixation.
If daily routine activity is not affected, then we can keep it like that. If too much restriction of movements, then we can go excision of the and the fat interposition in it.
No, see, now, your first part is right, Pavan. See, always assess the child. Don't be in a hurry to do this thing. Observe the child. See how the child is managing with his activities of daily living. If they are interfering with the activities of daily living, what are your options? What did you said, Pavan? What is the option?
So excision of the synostosis part and fat interposition.
Yeah. So how does that help? What is the pathology also in that? Tell me about the pathology in this case. Now you can excise the synostosis, fat interposition. That may prevent this thing. But does it restore the movement?
No, sir. Radial head is dislocated.
Radial head is dislocated.
So is that the reason why the movement is not obtained? What is the reason for not obtaining movement in spite of your surgery? You will set exercise a synostosis fat in the position that may prevent re-synostosis. Fine. But why is the movement still not obtained, especially supination? What is the pathology?
Radial head is dislocated.
Radial head dislocation.
Radial head dislocation, even in a Monteggia, unreduced Monteggia fracture, sometimes many of the patients do have good supination and pronation. And in fact, once you put it back fully, the pronation supination is restricted.
So supinator muscle will be absent in some cases.
Yeah, who said that, Ando?
Yes, sir.
Yes, good. That is the answer. The supinator muscle in most of these cases is undeveloped. That is why people don't, the patients don't get the supination. Now, what is the other option? So, osteotomy and interposition grafting is not a fantastic option. It's almost given up. Or excision.
So we do a osteotomy at different levels distally, sir.
Yes, exactly. If there is an inhibition of this thing, you put it in the functional position by an osteotomy in the distally. Exactly. Okay. Now, this is a 15-year-old boy, history of open fracture, both bone and forearm. Now, draining, you can see the picture, draining sinuses are there. What antibiotic would you start? Where will you take the culture? So, what antibiotic will you start?
No antibiotics.
Yes, we should withhold the antibiotic before taking the culture.
Okay, now where do you take the culture from?
I take the culture from the bone, sir.
Bones and the surrounding tissue where we are likely to find more viable.
Blood culture.
Yeah, one of the option is blood culture. From the bone, see, would you take the culture from the sinus?
No,
The draining
No, sir.
sinus.
No.
No, sir.
More
No,
like
sir.
contaminant.
It is always contaminated by common sense. Okay. Now, will you? What is the differential diagnosis? Will you send for histopathology? Will you send the specimen? You are taking the patient to the theater. You have curated out the muck. Will you send it for histopathology or culture and sensitivity or both?
Both.
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 Because culture,
We will send for
culture
a
every biopsy and
histopathology because
biopsy every culture.
So the common dictum is
every biopsy should be sent.
every specimen should be biopsied. Every specimen should be, all infections should be biopsied. All tumors should be cultured. Okay. Now, in this particular case, seeing the X-ray, will you now intervene surgically?
No, sir. In this case,
Why will you not intervene
not good
surgically? The
option
parents
for
are
the
pressurizing you.
Circumferential
in
involucrum
this
has not
case,
been found, sir.
Okay. That is one of the reasons. You want the bone to be strong. You don't want a pathological fracture now. So you wait till the bones have become strong. Most of the time, the sequestrum also will get absorbed. So generally, unless there is a pressing demand, repeated bouts of infection, generally I would not interfere surgically right now. I would sit on it. Okay. Now, 8-year-old boy, fractured tibia upper third, POP cast given. Okay, the fracture, comment on the fracture. The how yes, Karthik. Fracture is united or not?
So there is a unicortical fracture of the lat median proximal. Sir.
Yeah, but anyway, let's assume that it is united. Now,
Yes.
1 minute, please. എന്താ മോനെ ഇല്ല കഴിഞ്ഞില്ല ഞാൻ കഴിയുമ്പോൾ താഴോട്ട് വരാം രണ്ടും വേണം ചാറ് 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 ആ ചാറാ വേണ്ടത്
Sir, please unmute, sir. Sir, please unmute.
Yeah, sorry. Okay. Now, after POP removal, about 3 months later,
Cousin phenomena.
parents noticed a knock-knee deformity. Now, what is this phenomenon called? Pavan
Cousin.
phenomena.
Cousins phenomena, sir.
Cousin phenomena. Now, how will you manage it? Nandu?
It will get automatic.
Yeah, most of the time it will get automatically corrected. Suppose if it doesn't allow, how long will you wait? That is my question.
Till
I'm not sure.
Okay, let's ask
I'll-
Ando.
No idea, sir.
Up to sir 6 years, where there is a possibility of a correction of fissure.
Yeah, Sadish, what did you say? How long will you wait?
6 to
Sir,
7
till
years.
1 year, till 1 year, sir. Till 1 year.
Yeah, now the current consensus is
Patient age is 6 to 7 years. Current age is 5 years. So 3 years.
yeah, now the consensus is 3 years. Now, if it doesn't resolve within 3 years, what will you do?
Guided growth.
Hemiepiphysis, sir.
Yeah, hemiepiphysis. Now, why did I say 3 years? Now the consensus is 3 years. Why did I say 3 years?
Sufficient growth should be left for hemiepiphysis.
Yeah, no, it's not that you can have it will work. The reason is the cora, or the apex of the deformity, will move down to the diaphysis region. Now, when you do a guided growth up after 6 years or something, you will create an Z-shaped deformity, zigzag deformity, because the apex of the deformity is now gone down to the metaphyseal region. So you wait till 3 months. If it does not improve, then proceed. Okay. 1-year-old boy referred for clubfoot. See all the pictures clearly. Is it clubfoot? If so, why? If not, what is it? How would you treat it?
So it's a metatarsal.
Metatarsal adductor.
Yeah, now, why did you say that it is metatarsus adductus? What is the reason? Tell me the 2 reasons why did you say it is a metatarsus adductus? Both the pictures are given there. Yes, Dr. John C. John C is connecting to his audio. John C, please unmute yourself and your video on also. Yes. John C.
Sir.
Okay, let's try with Gautam. Yes. What are, you said somebody said metatarsus adductus. Gautam, what is the reason? Why is it metatarsus adductus?
Because the deformity is only in the forefoot.
Fine. Is it the only reason?
There is no medial crease. No.
Medial crease may or may not be there in a clubfoot. Partially treated clubfoot may or may not be there. So that's not an answer.
No,
Dorsiflexion is possible.
Yes, exactly. In a clubfoot, you will never get that much of dorsiflexion. Now, in a metatarsus adductus, where is the deformity occurring? Which part of the foot is the deformity occurring?
also metatarsal.
It's in the mid-tarsal joint, tarsometatarsal joint, or the metatarsophalangeal joints?
Tarsometatarsal joint.
Metatarsal.
Okay. Now, how do you treat this 1-year-old fellow?
Conservative treatment.
Conservative
Conservative
management.
treatment, yes, the parents are complaining that most of the time you don't need to do anything. But sometimes the deformity, you need to correct it with serial casting. So what is the method of serial casting you use? What is that famous author's method?
Reverse pons.
Pardon?
Reverse ponsity.
No,
Reverse
kites.
ponsity is used for what?
So that is called my vertical talus.
Yeah.
Okay.
So this is,
Kites.
yes, kite. Who's kite? At least which country is he from?
French.
France.
No.
French.
No.
No. French is Benza Hills, not kites.
Kite is long. Kite is long since dead, not alive also now. His name is Hiram Kite from Texas Scottish Rite Hospital. He developed this method not for metatarsus adductus. He developed this method for
CTV.
He developed this method for clubfoot,
So,
which was proved to be later wrong, but it was good for metatarsus adductus. Okay. Okay, the last one, and I will finish off after this. Now, 70-year-old boy. 1 minute, let me just see what it is. 7 days old baby, deformity foot. What is the deformity? What is the underlying problem? How will you correct the foot deformity? How will you correct the underlying problem? Okay, let's ask somebody who has not answered so far. Abin.
Congenital talipes echinovarus, CTEV.
Okay, it is a club foot. I do agree.
Club foot. Yes.
But what is the underlying problem?
Equinus is
Fibular hemimelia.
So there is a constriction band, sir.
There is a constriction.
Yes,
constriction
that
band.
is a
constriction, amniotic constriction band is.
yes, amniotic constriction band. That is the reason.
Yes.
That is, so what is this called? There is a name for that, which the examiners are very happy to ask.
Streeter's
Fibrous dysplasia. Yes. Now, how will you correct the foot deformity?
Serial casting, sir.
Yeah, most of the time, serial casting at least works to reduce the amount of deformity. You may need to do a posteromedial soft tissue release. Sometimes you may get it by the Ponseti method. But serial casting is the answer, at least to start with. And how do you manage
Sir, I
the
didn't
underlying
get the name of the deformity, sir.
amniotic band syndrome?
So what type of dysplasia? What is
Streeters. Okay. And how do you manage the underlying problem, the amniotic band?
That we'll have to release, sir.
No, what will you do for that? Probably you won't do it. Your plastic colleague will be doing it. What technique do you use to? Yes.
Soft tissue release.
Okay, Shinas, let's have an answer from you. You correct it with an isoplasty. That's what I said. The plastic colleague may be better off than us for doing that. Okay. So that finishes today's session. Any comments, any criticisms, any questions, anything you can ask me. You can mail me or you can WhatsApp me. Okay. Good night.
Thank you, sir.
Thank you.
Thank you. Thank you.
I think 10 questions are enough for every session, not more than that. Alla Balu?
Yes, sir.